11:04 here, Dr. Payne Show with Dr. Lou. I'm Chris Creston. I'm in for John Scholes, so I'm glad that you have me in
improvement on how you look, just right off the bat. You look.
He's better looking than John Scholes for sure. He's got hair.
That's not that hard.
That's not really.
You got Greg Carrasco here as well, continuing on from his show. He wouldn't. You can't get this guy to stop doing radio.
I know, man. I love this. He's
just taking this over slowly. He's just trying to push me back and back.
No, I happen to think that you are incredibly relevant in day-to-day life, and I'm not just blowing smoke. Because having gone through this knee surgery, I never really understood the concept of the stuff that you talk about here, and the prehabilitation concept.
Yes.
And somebody asked me last week, Greg, what did you do to prehabilitate yourself before the surgery so the rehabilitation became a lot easier?
A lot easier, right.
And I said, how about this? I'm going to see Dr. Payne on Saturday, and I will ask him on air, because I can tell you that the only reason why 16 weeks after a full transplant on my knee, I am able to be on the mat, duking it out with guys half my age, and I don't feel anything. I mean, knock on wood.
Yeah.
I'm being smart about it.
Yep.
But I attribute all of this to prehabilitation. Can you talk to me a little bit more? Because I'm not, just because I had this and I recovered quickly, I'm not saying that I'm not going to get injured again. I don't know.
No, yeah. I mean, that's, starting with the first point that you made about the relevance of what I speak about, one of the things that we talk about is we use pain as the sixth vital sign. So it's not a traditional vital sign like blood pressure, heart rate, but it is one of the things that distinguishes human beings. It means you're alive. If you're feeling something, you must therefore be alive, right? So that's how important this is. And this happens in everyday life. And then in like your circumstance, it doesn't happen until maybe you have to have a surgery. But to move over to the question of prehabilitation, how important is that versus rehabilitation? I don't know that I can give you an answer based on the research that I've seen that can quantify that. I can, for example, say, well, you're 50% more likely not to recover. Like, I don't know the exact numbers, and I don't know that research would exist even from an ethical standpoint where you would tell someone to try not to do something before it. But I can tell you from a practical experience that I would say that if I had to take a guess, it's probably 50-50. It's probably
really
just as important to be in good functioning form in that local area prior to a surgery as it is to get it functioning after. And yeah, I do believe it's that high, because it's just, if you're prepared, if your body is prepared for it, then, I mean, surgery is trauma, right? And we can define trauma in so many various ways, but to the body, there's no difference between a surgeon going in there with a scalpel and moving things around as there is me kicking out your knee, right? It's trauma. The body doesn't know the difference. And so the same types of physiological processes that would happen if I just kicked out your knee still happen with surgery. Now, the difference being some of it would be controlled to an extent with anesthetics, antibiotics, et cetera, et cetera. But there's still that same level of invasiveness that can't be discounted. So I do believe the prehabilitation is equally as important as the rehabilitation process. And I think the better, and this is the reason too why a lot of surgeons sometimes won't even do a surgery on someone. Like, a better example for people to digest just from an analogy standpoint is, if you want to get like a stomach band or something where you want to lose weight and you're severely obese, the doctor will tell you, well, go lose 100 pounds first on your own before I do it. And that's two things. Number one, the psychological side of things where, you have to build a habit of trying to get healthy regardless, because this isn't the solution on its own. And equally so with prehabilitation, you doing stuff before gets you in the habit that you will equally need to do things after.
And I don't think that people really understand the scope of being in shape. Why? Because when you're in shape and you get injured, you're still in shape.
I'll bring up a certain figure. I'm a bit of a fan of his, a guy named Jordan Peterson from UFT, okay? One of the things that he says in general, so this is based on the other things he talks about, but he essentially talks about that the sacrifice you make today is essentially the future that you are building, right? So you can almost know the future by the sacrifice you make today. And it's the same thing with being in shape. the sacrifice you make today is your future. The whole reason why, there's this whole push around being healthy. Why are you healthy? You're healthy not for today. You're healthy in the hopes that you've increased your longevity one day.
Have you read his book yet?
Oh, yeah. I've actually read it twice.
Really? I went to see him. I'm a big fan of his.
He's awesome. Yeah.
He's amazing.
There's a couple controversial issues, but
that's okay.
As a thinker, I think he's like up there with the best in the world in terms of making us understand what where we are in humanity and so many things. And a lot of when I read these things, I try to take it back to what I do every day, which is the healthcare aspect of things. But even that, the sacrifice, and that's what prehabilitation is. The sacrifice that you make prior is the future that you want after the surgery.
And the last thought before I get out of your hair, you have some, I don't, is that, I've always been a gym rat, whether it's lifting weights or CrossFit or jiu-jitsu, whatever, all the stuff that I do. But I did it because I wanted to be healthy, but I never really understood the whole concept of being in shape and being healthy until I got hurt.
Absolutely.
And then I understood the reason why, and everything became so clear. This is the reason why I am in shape. This would be paralyzing for someone. And, my surgeon said to me, Greg, if you were a couch potato and you were all out of shape, I would not be doing this to you right now. I would not be doing a transplant to your knee. But I already know that I'm going to have to hold you back on the other side of the surgery because you're going to be chomping at the bit, trying to get on the mat and fight with people again.
Yeah. And I mean, the crossover between things in life is there's really I was listening to your second hour with Calvin on, right? Same thing. The sacrifice you make today from a financial perspective is the future, again, that you want one day. It's and it's just same thing. There's no big secrets in life when you actually look at things that way. And it's no different in healthcare. You got to make the sacrifices day to day in order to increase your longevity, or at the very least, do your best to do that, because anything could happen. But if you can at least, I meet people where they say, yeah, but not everybody that smokes gets cancer, for example, gets lung cancer. Fine. But why not remove the variable that one day you can say, well, I know it wasn't because of that? Like, why not eliminate one very, very important factor that, based on research, is almost causation more than it is just correlation?
Miyamoto Musashi said that once you understand the way broadly, you see it in everything.
Yes.
Once you see the clarity, you can apply it to just about everything. I love you, man. Thank you so much.
No
Thank
problem.
you. Good to see you,
Greg.
Thank you so much, Greg. Thanks, Greg Carrasco, sticking around for an extra segment here on the Dr. Payne Show with Dr. Lou. I'm Chris Creston. Give us a call, 416-870-6400, star 640 on your cell phone, 1-888-225-TALK, and give us a call and ask Dr. Payne a question, just like Greg did, sticking around to find out a little bit about the knee, and hey, maybe a little bit about philosophy here as well, here on Global News Radio 640 Toronto. Give us a call, like the big voice guy said, 416-870-6400, star 640 on your cell phone for a question for Dr. Lou. Tell him about your pain. Dr. Payne is here to help.
Yeah, Dr. Payne. I got to change that name.
You don't like it? I think it's a good wrestling handle.
Yeah, I guess to some extent. It's funny. I've grappled with wrestling, pardon the pun. I've grappled with this, but one of the most important things with pain management with patients is to not focus on pain.
Right.
And if the first word that everyone has seen is pain, that's quite the way to not focus on it. So it's counterintuitive.
Gotcha. Doctor getting better here. We've got Dylan calling in right now from North Bay with a question for Dr. Lou. Dylan, what's up?
Hey, Dr. Lou.
Hey, Dylan.
Just giving you a call. I've never had. I'm much like Greg there. I've always been a gym rat, judo, boxing, all kinds of great stuff, and always been in pretty good shape. I'm 52 now, still in good shape. And the problem is, though, I'm having a sciatica problem on my right side down my leg, and I can't explain it. I've never had any trauma to it.
Yeah.
And I'm just hoping that surgery isn't the answer.
Okay. Yeah. So I mean, that whether surgery is or is not the answer will be difficult for me to say without obviously assessing you properly. But what I can tell you is, one of the things you just said there is no trauma. And see, the problem here is that people see trauma as an incident, something specific that they could say, yep, I was picking up a box or I was lifting that weight and then boom, there it was all of a sudden. But trauma is also cumulative, and it might be cumulative based on functional patterns that are just characteristic to you. So what do I mean by that? Like, let's use the example with, let's just say you have a slight scoliosis, which is a little bit of a little extra curve in your low back. And, over the years and all of the things that you do, that wears things down in a different way. Like, I mean, we just had Greg on the show, so relating that analogy to cars, right? If your alignment is slightly off to one side, well, it doesn't cause an instance of trauma, but what it does do is cause a cumulative effect where all of a sudden that car in that area will eventually break down. And our bodies are really no different. We're a more complex mechanical creature, but with the same basic principles, in that if you continue to do something functionally in a certain way, and nobody has, I always say the people who are the ideal specimens, those are the Olympic athletes. That's why they are who they are. But the average person like you and I and Chris here and Jody, we're not the Olympic athletes, and so we have these things that will eventually lead to breakdown. So, your sciatica may very well be due to the way you've lifted your whole life and a certain pattern. And although it may take, I don't know your age, but whether you're 30 or you're 40 or you're 50, it's just where does the straw finally break, right? Like where is the point where all of a sudden you feel pain? And we often speak about pain or serious pain like you're having with the sciatica as the end stage of dysfunction, right? So there's a dysfunctional thing happening prior, but all of a sudden you feel pain finally. And so, that's the first point there. The second point as to whether you would need surgery or not, that's a more complicated question in the sense that obviously I would need to assess you. What I can tell you is oftentimes surgery for these types of things is often not needed. One of the stats that I can give you is out of 100 people that a spine surgeon sees that are referred to him or her, they operate on about 2 or 3 of them. So what that essentially means is when you're dealing with the spine, 97% of the cases that people think might be surgical are not surgical. So those are just the stats. Now, am I telling you you're 97% versus 3%? I don't know. I'd have to get more information, but that's where the assessment is most important.
Right. Thank you.
Okay.
Most of the problem occurs when I'm been sleeping or sitting for a long time.
Right.
Walking, jogging, biking, running. Never have a problem with that. It's after I stop and it starts to...
Yeah, and so that starts to provide relevant information in the sense that once you understand anatomy, like as soon as somebody says bending or sitting, aggravates, that to me suggests some type of a disc issue, like a disc herniation or a disc bulge. And now there's a difference between hurt versus harm in the sense that you could do certain things that hurt you but are not necessarily harmful, but equally so you can do things that don't hurt you at all but may equally be just as harmful. So again, that's where breaking it down patient to patient and individual to individual is very important for finding what those points are. So, and the example there that you gave is, yes, sitting is harmful for a disc issue and equally hurts, but you're saying running doesn't hurt, but it may actually be harmful. I don't know, because again, I would need to go into a deeper history and physical exam with you, but it is important to distinguish those things.
Well, thank you for your time. And
no problem.
I left my number as well, too, for follow-up.
Okay, thanks.
Right.
Awesome. Thanks a lot for calling, Dylan. And if you want to follow up with Dr. Lou, 1-855-55 Dr. Lou is the number to call to get a hold of him. Or if you want to call, and like Dylan did, and call and ask a question here on the air on Global News Radio on the Dr. Payne Show, 416-870-6400 star 640 on your cell phone. A whole lot more with Dr. Lou coming up on the other side. Global News Radio 640 Toronto, Dr. Payne Show here with Dr. Lou. I'm Chris Crescent in for John Scholes, who is off. I don't know
what a slacker. Just
come on. Speaking of slackers,
Greg's number one slacker. He's never here.
Well, I'm enjoying being able to spend some time here with Dr. Lou, learning a lot about people's pain, getting over it, finding a way to recover after surgery, like we're talking with Greg about, and taking some calls here from the listeners who have questions as well. Thanks a lot,
We'll
Dr.
have to
Lou.
replace Scholes.
So, you know what? The last caller did remind me of a little mystery pain thing I want to bring up with you, but let's get to the phones before that, so you can give us a call, 416-870-6400 star 640 on your cell phone. I want to get to David here before we get to my mystery pain. David in Brampton, what's your question for Dr. Lou?
Okay, I've been running for about 50 years.
Okay.
And I used to do marathons, and then I cut it down about 10 years ago to half marathons. And now I'm running maybe an hour a day for about 10K. Mm-hmm. And recently, maybe a month ago, I started to get pain both above and slightly below my left knee. Mm-hmm. And I've been walking strenuously now for the last week. And the pain actually only occurs maybe an hour after stopping running or stopping walking even. And I'm wondering, how long should I wait before being more proactive. That is either increasing the walking or cutting back on my running.
Okay. Have you had your knee looked at professionally by anybody?
Yeah, maybe about a year or two ago.
Yeah. So, but not recently, not since this recent exacerbation.
The pain, actually used to go away, and even now sometimes it goes away.
Right.
And I got new running shoes maybe about 3 years ago. And I'm getting older, but I really love running.
Yeah. Well, so here's, I mean, the answer for being proactive, I would say, is get this assessed properly, right? And start to figure out exactly what is going on. Because, I mean, is rest important? Sure, but it may not be necessarily the answer.
Right.
And one of the things that I constantly talk about is this again, and I'll use the word again, this cumulative nature of injuries. And a lot of people will have, like, you're a good example of, yeah, I've had knee pain before, but it would usually just clear up. And then all of a sudden they get to one point in their life or one instance where they say, you know, that knee pain that used to clear up, it's just not going away on its own anymore. It's actually, in fact, getting worse and it's bothersome. And so this is where I'm a big proponent of. That's why you should be getting the little things looked at initially and doing the functional things or the modifications early on so you never get to that point. But I mean, we're not going to deal with the past year with you. What I will say is what you need to do is get it looked at now and find out what's exactly going on. Because, I mean, the way you would treat a functional knee issue, say like a patellofemoral pain or otherwise known as runner's knee, is very different than the way we would treat, you know, a torn ACL or a meniscal tear or maybe osteoarthritis of that knee. And some of those may require completely, stopping running versus others may only require a modification, and maybe another one may require no change whatsoever as long as you rehabilitate it properly. So it's a very hard question in the sense that I need to know exactly what's wrong with your knee in order to make the right recommendation. And that's why I always say that treatment is predicated based on the diagnosis, because that's the way it works. You can't go backwards. And this is a big problem in our system where people are always, they'll say, oh, my friend told me to go try, for example, shockwave therapy, which has tremendous value. We do shockwave therapy in our clinics as well. However, you need to make sure that you're lining up the treatment intervention with the right diagnostic criteria, because that's what ensures the prognostic success.
So you're saying I should be proactive, not try to self-medicate? Or...
Yes. There you go. Good summary. I just said it in a long, complicated way.
Right. Thank you very much.
No problem. Give me a call.
Bye.
Thanks a lot, David. You can follow up with Dr. Lou at 1-855-55-Dr. Lou. That's 855-553-7568 or info at paincarecanada.com. Dr. Lou, I teased a little bit before. I've got a bit of a mystery pain, and I hate to be selfish and take up the airwaves here, but I've got a doctor here in front of me, so I might as well talk to you. And Dylan sort of sparked my thoughts on this because he was complaining about a sciatica issue, which is something that about a year ago I started feeling, and it was right down my left leg, sort of started around the low back, through the glute, and down into my left foot. And I went to my doctor at the time. She said, oh, you know what? This sounds like a herniated disc to me. I don't know. She jumped right to the furthest possible conclusion, but that's where she went with it. She told me to go see a physiotherapist, didn't order any imaging or anything. After doing some physiotherapy, doing some core strength training and stuff like that, trying to just sort of alleviate some of that, started to get a little better. IMS treatment, things like that. And went in for imaging finally. They couldn't find anything wrong with the disc.
Right. So, and then this is, so again, so we got to start, let's start at the beginning here. So you've got sciatica, right? Sciatica is just, the sciatic nerve is a big nerve that's made up of the lower lumbar segments, the nerve roots there that goes into, goes through the glute, out what's called the sciatic notch, down your leg, splits into the lower leg. So it's essentially a very important nerve in your leg. So sciatica is the term for pain in that nerve, okay? So when someone says they have sciatica, it's just really, it's like saying you have a fever, right? You wouldn't just go in and say, well, I feel really hot and clammy and blah, blah, blah. Well, then that's called a fever. The same extent where people come in and say, I have shooting leg pain, it's throbbing, blah, blah, blah. Well, that's sciatica. So that's the clinical sign. The next question becomes, well, what is aggravating the nerve? A lot of things can aggravate nerves. One of the problems with healthcare as well is that doctors or other healthcare professionals jump to the most likely cause of these types of things, right? And so if you had to look at the literature or what's most commonplace, you would say that sciatica is often a result of a disc herniation or something like a disc herniation or some other type of disc pathology. However, what we're not accounting for is that there's a lot of things that can cause that presentation. And you're probably a good example where you probably didn't have a disc herniation, because those things don't necessarily tend to disappear on imaging. You would just see them. They just wouldn't be pushing on the nerve root anymore because you've done enough to, at the very least, remove the impingement factor, but not enough to actually take it away completely, because disc herniations, its very nature is that there's a rip in what's called the annulus, which is the outer layer of the disc, and then the nucleus pulposa, which is kind of this jelly substance within the disc, protrudes out. You can get the protrusion
kind
sort
of like squishing an Oreo
correct.
cookie.
Yeah, you can, exactly. Yeah, you can get that back in, but you can't repair the rip. Or at least we're not good at repairing the rip. So one of the things that's often mimics a disc herniation is just the tight piriformis muscle. So I said that the nerve goes through.
I wrote down piriformis. My wife is a part-time yoga instructor and kept telling me it's your piriformis.
Yes.
I never heard of that.
Yeah,
Dr. Lou. Okay, my wife
is right.
Dr. Lou,
she's right. That's it. That's how
big. I told you so is coming to me when I get home.
There you go. So now again, I don't know for that for sure, but I mean, this is the important thing to consider. What could potentially be causing the problem?
Mm-hmm. Thanks a lot, Dr. Lou, for helping me, and we're going to get some more help for some other people coming up on the other side here. 416-870-6400, star 640 on your cell phone. More with Dr. Lou coming up. Dr. Payne Show here with Dr. Lou. I am Chris Creston. We're taking your calls on issues that you're having and solving some of my problems selfishly here in the process. 416-870-6400, star 640 on your cell phone. Let's go to Ed in Beamville right now. Ed, you've got a problem with your shoulder.
That's correct, I do.
What's going on?
I've got some pain there.
Yep.
That's been going on since last March. I was seeing a chiropractor. She was doing range of motion treatment, which just provided a little bit of relief, and it just kept getting worse. And I'm a really active guy.
Mm-hmm.
I do a lot of cycling. I do a lot of cross training, blah, 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 and strength training, just on my own, mostly body weight.
Yep.
And I like doing that, and I like the way it makes me feel and look and everything. But I got in to see a sports medicine doc, and he looked at everything after I went to get diagnostic imaging,
mm-hmm.
and they said there's a calcific tendinosis of the supraspinatus tendon.
Yeah, calcific tendinitis. Okay. Yep.
Yeah, a focal tearing of the distal subscapularis tendon.
Okay.
So, anyways, back in June, I got a cortisone injection, and it worked wonders.
Mm-hmm.
But the pain came back.
How long did it last for? The relief of pain.
A good 4 weeks.
Okay.
And then I did a workout, and all this, and I got workout pain, in my pec. But it was good pain. But then the pain in the shoulder never went away after that.
Right.
So I just got another cortisone injection this week, and the sports medicine doc is recommending that I wait a couple of weeks and go for some shockwave therapy because supposedly to break down
the calcific tendinitis. Yep.
Tendinitis.
Yep.
And I'm wondering about that. I've never had it. I've heard about it. I'd like you to explain, if you could, what happens and how that helps, if it does help.
Yeah. So, I mean, based on the research, shockwave therapy is very good for two things based on the scientific literature, one of them being calcific tendinitis and the other being plantar fasciitis. So, does it work? I mean, I'd have to say based on the research, the answer is likely. Now, research is never one-to-one. It's not 100%, right? Like out of 100 people, maybe it helps 75, 76, something like that. But those are very, very good odds. So yes, it does tend to work for those things. The process by which it works is this shockwave, which originally came from the technology that they were using to break down kidney stones. So it's just essentially these shock waves, essentially is what they are, that are sent in to break down the kidney stones. Now, like many things, there's applications in other areas of health. So the example being laser therapy. We have lasers that we use for the treatment of musculoskeletal injuries to help blood flow, but we equally have lasers, that can go into a person's spine and remove a disc, as we equally do where we do eye surgeries with them. So there's different applications, and shockwave therapy has a musculoskeletal application, which is the one you're talking about, where it does break down the calcification of that tendon. Now, you have to kind of go back and understand what calcific tendinitis is. Anytime the body calcifies, it's hardening. And tendons are not meant to be hardened. They're supposed to move a certain way, especially the supraspinatus tendon has to move a certain way to allow for the rotator cuff muscle to do what it needs to do so that the shoulder can do what it needs to do. Well, if there's something impeding on that mobility, that can create a problem. And so that's the whole idea, is if you can break down that calcification and have a little bit more mobility, you should have, an improvement in pain. One of the things that I will say when it comes to shoulder injuries, and especially things that affect the supraspinatus, and this is a little bit hard over the radio. The supraspinatus is a muscle, part of the rotator cuff muscles, that sits at the top of essentially the shoulder blade. It comes under the acromial hood, which is the extension of the scapula and the clavicle, and it goes through this little hole to attach into the arm. Depending on posture and the things you do, you can make that space where that tendon goes through smaller or bigger. So one of the important things around shoulder injuries is making sure that the person has what's called good scapular positioning, so that their scapula, their posture of their scapula is working in such a way that it maximizes that space. And that's often one of the things that's forgotten. So the only reason why I bring that up is, if you just do shockwave and you break down the calcification and it's sort of better, if you don't change the posture around potentially that space where the supraspinatus is being impinged, then you likely could still have pain, or the pain could come back.
Yeah, I'm hearing you loud and clear, because I did see a physiotherapist, and he claimed the cause of it was postural, and he gave me some postural exercises, which I did.
Yeah, and I mean, cause and effect with all of these things is hard to determine. But I mean, going back to the way I started this show with our first caller, was that I talked about the cumulative effect of the different things that we do. And yeah, maybe the physiotherapist is right. It's the cumulative effect of the posture of your shoulder that has eventually led to the calcification, and eventually that calcification catches up with you in the form of pain.
Okay. So when you're saying scapular position, are you saying to go back to see a physiotherapist to make sure I'm getting
so again, this is a harder question to answer, because physiotherapist, chiropractor, massage therapist, sports doctor, I know some massage therapists that are better than some sports doctors, and I equally know some chiropractors that are worse than massage therapists. Like, there's so many different ways. It really depends on the individual, that if they, it's like anything, like you can have 10 different accountants do your accounting at the end of the year, and they might have 10 different opinions on it. This is the same with healthcare and with physio versus chiro versus massage. It really depends on their outlook. But I can help you find somebody that I think would follow along with my train of thought here.
Okay.
Thank you. No problem.
Thank you for the call.
Thanks a lot for calling, Ed. And Ed, you can follow up by calling Dr. Lou at 1-855-55-Dr. Send him an email, info@paincarecanada.com. If you want to ask a question on the air like Ed did, give us a call, 416-870-6400, star 640 on your cell phone. Just expanding from Ed's call, we're talking about sort of that repetitive nature of whether it's a posture issue or a motion that we're always doing. How much of that, like when you're talking about guys who are in the gym a lot, how much of that can be from just not having the right posture while doing a certain exercise? Yeah,
I do believe, again, going back to the beginning, I do think a lot of the injuries that we eventually sustain, if you're, I can, it would be a long cross-sectional study, but I'd love to have a group of kids that someone could analyze and say, well, based on their postures, these are the likely injuries that they will happen. And then when I analyze people, this is, I can look at them and say, well, just based on this very nature, here are the types of things the injuries that are common. The reason why I don't like doing it is because then you're almost creating a self-serving body. Like you're almost putting that in their head. So there's that loop where, is it created because it was going to happen or because you made them believe it was going to happen? So that's a very dangerous thing in that sense. But yeah, I do believe that the posture or your let's call it the dynamics of your body, right? Because posture, everyone just thinks about sitting up straight. Mm-hmm. But let's talk about functional dynamics of your body do predicate the certain injuries that you would be more predisposed to, for sure.
Interesting stuff. I'm learning so much here with Dr. Lou, and I hope all of you are too. Give us a call, 416-870-6400, star 640 on your cell phone, 1-888-225-TALK, to give us a call live on the air and ask Dr. Lou a question here on Global News Radio, 640 Toronto. Good morning to everyone out there. Beautiful Saturday morning here for, I can't imagine a better way.
They're not going to last much longer.
I know. This is likely the last great Saturday morning that we're going to have here here for the remainder of 2018.
Or somewhere like in December, right? Like with our weather, it'd be like snow, and then all of a sudden 30 degrees.
Yeah, exactly. Just turn on a dime here. We're taking your calls, talking about pain that you're experiencing, things that you're feeling. I know, Dr. Lou, I get really irritable when I have pain, and I'm just a horrible person to be around.
Human. Yeah, for sure, of course.
And that's got to be a big problem. So you want to turn that around in your life, and it all starts with getting it figured out, talking to your doctor, and moving forward with some kind of treatment.
Yeah, and besides becoming irritable, like one of the things too is that what people don't realize, like there's a big focus, like we can name how many like foundations, like heart and stroke cancer. These are all things that will affect potentially the quantity of your life. And I'm not downplaying their importance. They are extremely important. Whereas pain is one of those things that, in general doesn't affect, even though I can argue that it potentially could affect the quantity of your life, but it's more about the quality of your life. Right. And this is really what we're dedicated to. How can you get what you want out of your life, right? Like I see people who are high-end golfers, for example, and they want to keep playing golf, but it's like, well, you have a choice. You can keep playing at this level and then never play golf again for the rest of your life. Or if you somehow tone it down or you rehabilitate it properly, you can play golf one day with your grandkids, for example. Right. Like, and this is, and again, going back to what we were speaking about with Greg, the sacrifice you make today is the future that will therefore be in front of you one day, right? So you can make that happen by doing the right things today.
Yeah, and you want to be able to do that and hand that experience on to your grandkids, like
quality
you're saying.
Should be equally as important of quantity of life. And I think all of us would agree, like if someone said, could you live 60 years with the best quality of life, or you choose 100 years with not so good quality, I think most people are going to choose 60 years.
Yeah, you want that quality in there. And we're hoping to get some of that quality in for some of the callers here on the air right now. 416-870-6... that's not a whole phone number. 416-870-6400, *640 on your cell phone here. Gail in Toronto is giving us a call here with a question for Dr. Lou. Gail, what's happening?
Hi, I had osteoporosis in both of my thumbs. It was really bad. I had all kinds of treatment. Anyhow, finally recommended to have surgery, and I had surgery on my right thumb, and I was planning to have surgery on my left. Ironically enough, when my right thumb got better after the surgery, the pain in the left thumb went away, and it was about 8 years ago, and I have never had it return. Mystery.
Okay. So what's the question, Gail?
Why would the pain go away in the left thumb after the right thumb got better?
That's a very, very hard question to answer. I mean, there's a couple different ways that I can answer that. One of them could just be, it's just coincidence. A lot of times, people think that just because something happened at a certain point in time that it's a causation, right? So the example being like, you're sitting there, you get surgery on one side, but the pain goes away on the other side, and you're assuming, well, one is equal to the other, but it may just be a correlation, like something may have happened. So there's that side of things. There's also from a neurological side, and this may be stretching the limits of what's possible or what most people can accept, but there's something called mirror box therapy, and this is reserved mainly for people who have phantom limb pain. And so phantom limb pain is a very, very dangerous or very, very serious thing and very hard thing to treat. And what the mirror box is let's say you are missing your right arm for whatever reason, okay? You put a mirror box where essentially your left arm, you're looking at the mirror and the reflection of your left arm looks like your right arm. Now, people can start to treat that phantom limb pain by looking in the mirror with the perception that that is their right hand and doing things really with their left hand. So there is sometimes a crossover effect in the body where, one side of the body can affect the other side of the body. But again, and that goes deeper to a neuropsychological level, which again, I'm not sure if that's the answer here, but I also am not sure what the answer is because, again, I would have to go through your history to understand, but I would need to go through the extent of possibilities to look at why could something like this happen, and that would be my guess that it would either be something along those psychoneurological routes or just pure coincidence on why it would get better. Like if I'm understanding correctly, your surgery was done on one side, but the improvement you felt was on the side without surgery.
Both sides.
Oh, you had surgery on both sides. Okay, sorry. So then I misunderstood.
No. I had surgery on my right thumb. it was going to be followed, the surgery
on your left thumb. Right. Okay. So I understood it correctly. And then your left improved. Right. So yeah. So again, either just purely coincidence or some psychoneuro effect that is very, very hard to explain, with the time that we have left. But I would say that would be sort of my two hypotheses.
Thank you.
No problem.
Thanks very much for calling, Gail. Really appreciate it. Let's move on to Marcel in Toronto. You've got a question about your knee. Marcel?
Hello.
Hey, what's going on with your knee, Marcel?
I had a meniscus tear on my knee a little while back, and from it, I got something called a Baker's cyst on the back of my knee.
Mm-hmm.
And I'm supposed to be going for an MRI in November.
Right.
And I think I'm going to have to get some orthoscopic surgery. My question is, how long will I be off if they do something like that?
Again, and then so that I believe that's a better question for the surgeon, because the surgeon will understand the extent of the exact issue that you have, the exact type of surgery that they're doing, and also your current prognostic factors. Like, have you done stuff before to make sure that your surgery goes well after? Do you have any other comorbidities, like, for example, diabetes or something like that? So I would say in general, like a scope surgery, if it's the average scope surgery and you are a perfectly healthy human being, you're probably looking at a 4 to 6 week recovery, maybe 6 to 8 weeks, depending on age. But again, those numbers very much change. Like Greg was a perfect example with ACL construction, right? Very healthy guy, very fit. He was better almost instantly when I was like talking to him after surgery, versus most people would have said that type of surgery, you'd probably be out of commission for 3 months. And, almost 5 months out since then, he's doing perfectly fine. So those things can range very, very much. It really just depends on you, the individual, and understanding the parameters around you.
Very good. I know that pain usually shoots down. Now I'm getting a bit of pain on my left hip. Could that also be from the knee?
It's the left.
Yeah, it's my left knee.
Yeah. So there's a lot of things around compensation, right? So when you have, like, just as an example, your left knee is hurt, that means you have to sort of change your gait, and that can essentially affect anything else. It can affect your left ankle, your right ankle, your neck. Like, once you start shifting patterns in your body to do things, well, then that force has to dissipate the whole way up your body, all the way up the system. So yeah, you could potentially feel it anywhere, and it would be most likely that you would feel it in the next joint to that local joint. So somewhere like a left knee issue, it's not uncommon for me to hear that people are now feeling stuff in their left hip. It's just kind of the next area that will take the brunt of the abuse.
Very good. Because I drive for a living, so I thought that might also be affected.
Yeah, and exactly. And so those are the types of things that are important to know with prognostic factors. Like, sitting is very much like you're not doing much, right? So maybe your cardiovascular system is not as good as it could be. So, maybe prior to surgery, you want to start walking 20 minutes or 30 minutes, 3 to 5 times a week to get your cardiovascular system up. And these are all the things around why an assessment is so important, because I need to assess the individual. There's so many variables here that need to be taken into consideration.
I do a lot of stretching. I was overweight. I've lost 40 pounds. I cycle.
So I mean, your prognosis might be good then. I would need to go through the extent.
Very good.
Thank you.
Thank you very much for the info.
Thanks very much for calling. Thanks. If you want to follow up, call 1-855-55-Dr. Lou. Thank you. We've got some time for some more calls on the other side. 416-870-6400. Star 640 on your cell phone. A little bit more with Dr. Lou coming up on the other side. Closing in on the final segment here of the Dr. Payne Show with Dr. Lou. I'm Chris Creston, in for John Scholes, who generally brings the pain to Dr. Payne Show. I give him a low blow here when he's not here to defend himself.
Were you there that day, Jody, when I explained that? Yeah. He's the pain and Dr. Payne.
Anyway, I feel bad now that I gave the guy a shot okay. when he's not here to defend himself. Okay. But, we were just talking when off the air from the previous caller who was saying, well, he's got this knee problem. He's going to go in for surgery, but he's noticing a problem now in that hip.
Right.
So, and we're talking about how you compensate for that. And I was just thinking that, there's this sort of, it's almost like a bro thing. It's a guy thing that we're always thinking, walk it off.
Yes.
You don't have to go get it checked out, but you've got to be proactive with these things.
Absolutely.
Because a problem with your knee becomes a problem with your hip. And then all of a sudden you've got two problems to deal with.
And that's absolutely true. Like, I mean, the breakdown in one area of the body can absolutely lead to the breakdown in other areas. Once you start compensating in a certain manner, or you can't use that area in the same manner, like the knee is funny because people who have, like, say, for example, osteoarthritis of the knee, that I see that eventually need a knee replacement, they'll come in and it's like, yeah, it was only this left knee that used to hurt, and I know that's the one that needs the replacement, but now my right knee's hurting me more than my left knee. It's like, well, you're compensating, right? Like, you're doing things so that you can continue with your ambulating, you're walking around, and you need to make modifications in order, and your body will naturally do that. That's the thing, right? It's a good example of it when people have a disc herniation, for example. You'll see them standing up and they'll have an antalgic posture, which just means they offset themselves. They look like they're crooked, essentially. But that's not them doing it. That's their body saying, hey, we got a problem in this area, so I'm going to offload pressure in this area. But what happens to your upper back, for example, when you're crooked like that? These people do start to develop, I've also got upper back pain, my neck's bothering me, like I feel like my feet are hurting. And of course, the one thing can lead to another. But I equally mentioned on the other side of the break that there's a balance that you got to find. And the example I gave is, sometimes I'll have moms come in with their young kids, like 6-7 years old, and they've noticed, the kid has flat feet, and it's like, kid needs orthotics, or what they deem to be. And it's like, well, does that kid have any problems? And if the answer is no, you also somehow...
So are they feeling pain?
Are they having pain? Exactly. Then you also have to accept that inducing a change, right, making a change can also lead to pain. And the example that I gave you was a dentist putting in braces, right? Like, if you go to where you want to be in 6 months from now, it's going to hurt like hell. And the small incremental changes get you to where you want to be in an effort to limit that pain over a longer period of time. And this is the balance you need to find. Like, when do you make an intervention so that it's not too early that you induce problems that shouldn't be there? And when do you not do it so that it's not too late and leads to other problems? And again, that's where I think finding the right healthcare professional is that answer. Because if you have the right person who's helping you along with, for example, these musculoskeletal issues, they will be able to find where that harmony is, where that perfect balance between those two is, or at least have an idea where it is, so that you're never intervening when you shouldn't, but intervening early enough when you should.
Hey, thank you so much, Dr. Lou. We're wrapping up the show here. Just a pleasure spending the hour here with you. Dr. Lou's Pain Care. You can give him a call, 1-855-55-Dr. Lou. info@paincarecanada.com, or visit paincarecanada.com. I think we're going to do it again next week.
Yes,
right?
I'll see you next week.
Awesome. Terrific stuff. Dr. Lou here with you. I'm Chris Crescent. Stay tuned to Global News Radio 640 Toronto.